My presentation today has to deal with multicultural approaches to medication use, and it is about medicines and how cultures approach medicine. And it's interesting because you might be a single population in a single point in time living together in a single space, like Des Moines, but you have different ethnicities, different race groups, different dietary preferences. So in a sense, people approach their healthcare and medicine use differently. Before I start, I just wanted to get an idea of what you thought the definition of culture was. What do you think culture means? And I do not want to be like I am with my students and say, I'm going to pick on someone to tell me.
Do you want to speak and see if it's any louder?
Is this okay? Can people hear me in the back? Okay.
Okay, I'm going to...
All right. Yeah, go ahead.
A set of traditions passed down from one family member to the next.
Yes, it could be traditions. Traditions that... Yeah, no, go ahead.
It could be.
True, it can be food, it can be a belief system, it can be a value system, basically. So it's all of those sorts of things that we're going to talk about as well. I thought I'd just tell you what... Am I going the right way? There we go. Here's some of the Wikipedia and other kind of definitions of what a culture is, including the US government, by the way. But basically, I look at it as the creative interchange of numerous ethnic and racial subcultures in one population, living in one place at a specific point in time. So why should we care about culture and medicine use? In the US, it's actually patients and the community are a lot more, what's the word I'm looking for? Not aggressive, but upfront about what they want their healthcare to be like and what they want out of their healthcare. But in other countries, it's only now that patients are starting to see their rights about this kind of situation and to be able to say, hey, this is not a passive interchange, but I actually can have some interaction with this. So they're starting to become a little bit more active in this decision-making process. And they want to know more about the medicines that they're taking, how they should be used, and they want their lives not to be revolving around medicines, but for medicines to fit into their lives and lifestyles. So what they believe about medicines impacts greatly on how they use them and how they take them, and whether they will take them as instructed as well. So there's different things about it. The thing is, like, what value do they see about taking that medicine or staying on that treatment? And do they have a positive or a negative attitude towards medicines? Is there anything in their belief system that's actually going to prevent them from actually continuing with their therapy or participating in healthcare services? And there's actually very little research internationally about how these issues, whether it's faith, whether it's diet, whether it's tradition, whether it's any of those sorts of things, actually impact on how medicines are used. So I'm going to go through a series of a few case studies that have actually tried to look into this situation. And basically what I'm going to cover are issues in relation to race groups and how they approach medication use, gender very briefly, and culture more in terms of religion and diet, basically. So one small part of the culture definition, which is about religion and about diet. So the first research is something that I did with my students back home in South Africa, and we looked at differences in attitudes towards medicines between different population groups. South Africa is actually very, sorry. Did I go back too much? Okay, so the aim of the study was to look at whether there were differences in attitude between demographics, so gender, race groups, age. I'm not going to cover medication knowledge and self-care orientation in this particular presentation or medication use, but ask about, did their attitude impact in any way if they had contact with any healthcare worker in the last 6 months? So, you know, if they had a contact, were their attitude positive or negative? This is where I come from. Durban's on the east coast of South Africa. Very beautiful city, very warm. I'm sure lots of you are thinking that's a nice place to be right now. So am I. It's one of the most populous municipalities in the province that I come from. This was done in 2007. At that time, it was 2.5 million people. It's gone up to about 3.8 at this particular point in time. Very unlike Des Moines, I'm sure. We have approximately 8 million people in South Africa. It's about 50 million in terms of the latest census data. At that time in 2007, there were 276,000 and plus telephone lines. We're down to 140,000 fixed telephone lines because everybody has a mobile phone these days. And we actually decided we will try and interview about 1,000 patients and see what they, or 1,000 people, and think about what their attitude to medicine was. So like I mentioned previously, the three important areas I'm going to cover are things like what we looked at in terms of demographic differences, attitudes towards medication, and whether they had any healthcare contact, and how did that impact on their attitude towards medicine. There we go. So here's the thing. How many of you tried calling people during the day? Not very successful. So we ended up getting only about a 50% response rate. So first of all, only 80%, it was about 88% of those lines were actually still in existence. So even though we had a telephone directory of that year, by the time we called in June, July, already people had disconnected their lines. And some of the reasons why we didn't have people respond is they were either not interested because it was the winter vacation back home, there was no answer, or the telephone lines were busy. And those were not females on the telephone while those lines were busy. So what did we find? Well, our group is between the ages of 18 and 35, predominantly females. The race group that was predominant in the sample was Indian, and that was fine because, remember, Durban is, South Africa was part of the British Empire, and we had a lot of indentured laborers come across from India while it was part of the British Empire. So the second largest population of Indians outside of India is actually in South Africa, and predominantly in Durban, because that's where the sugarcane farming and all of that was. So that's kind of expected, and at the moment you can find that they're quite economically, they're sort of affluent, so fixed telephone lines is a sign of affluence in South Africa, and so you'd expect that to be common. So we had most of them being Indian. Most of the sample had a positive attitude towards medication overall. They were more likely to look at certain conditions and say, I will treat those myself and medicate myself, so they were more self-care orientated. And most of them had had a healthcare worker contact in the last 6 months, and about 50% of them had seen a pharmacist in the last month or so. But what does it talk about in terms of gender and age? I don't have the gender ones up, but females were more likely to have a positive attitude towards medicine than males, and females were more likely to actually seek out healthcare contact or seek out treatment than males were. So females were generally the ones who would say, if I'm sick, I will go find someone to talk to. But if you look at race groups, the black and mixed race group actually thought medicines were good. They had a positive attitude and they said, it's fine, it's a good thing to do. But whites and Indians said, they're necessary, but not necessarily good for you. And that points to the fact that actually this race group would more likely than not complete their course of medication. So they'd start something, but they wouldn't finish it. And if they were on chronic medication, it's a problem, because you had to continue then see that they would take their medicine as directed. And we also found out that if they actually saw a doctor or a pharmacist in the last 6 months, they had a more positive attitude towards medicine. So if you were not going to seek medical care, you actually did not have a good attitude towards medicine. So that took care of the race and the gender issue. But we didn't talk about religion or diet. And there are issues when you talk about faith, more specifically about the fact that the Judaism and Islam prohibits pork, and Islam also prohibits alcohol intake. And then you have Buddhism, Hinduism, and Sikh, where being a vegetarian is actually a sign of being spiritually inclined, basically. But then you also have people who, out of dietary choice, are vegans or vegetarian as well, and they don't want to have any animal products in whatever they eat. And why is this an issue? Well, the issue is the fact that in the manufacture of a medicine, you have something called an active pharmaceutical ingredient, and that actually is the product that has the effect that you want it to have. So for example, something like nifedipine is used in hypertension to manage your blood pressure, but you don't have nifedipine alone in that particular medicine. You have what we call bulking agents, and those can be lactulose, those powder, that can be glycerol, glycerine, glycerine. If you're making a capsule, so if it's not a solid tablet, the capsule cover is made out of gelatin. So there's problems because in most cases, gelatin is generally of animal origin and generally pork as well. Glycerol and glycerine is not such a problem anymore. It might be but almost all of them have gone to vegetarian products for that. Stearic acid, which is something else that's used as a bulking agent, are also mostly from vegetable sources, but you still have to check on those two ingredients. And lactose is the sugar that's present in most of these medications, and it's mostly used for chewable tablets as well. So those are the ingredients that are problematic. So who has studied things about religion and the use of medication? There was a small study that was done in UK with Muslim patients, and they tried to look at the influence of faith on the use of medication as well. And because of the fact that a lot of the medicines that were being used did have some alcohol or pork products in it, they wanted to see what patients would do. And this is where the concerns started coming in. More than two-thirds, or almost two-thirds of the patients would actually stop taking a medication if they found out it was haram. And haram means something that's not allowed in your religion, so it's not part of the rules. You shouldn't be taking it. And that they found that actually only about a quarter of the patients would take a medicine if they were not sure about it. So if they took something and they had a doubt about it, only a quarter of them would actually take the medicine. The rest of them would take it and leave it on the shelf at home. They would do nothing about it. And then they also state that 58%, so that's again two-thirds, stated they would stop taking a medicine if they found out that it was actually not allowed in their religion or it contained an ingredient that was prohibited in their religion. But it did change depending on what type of condition you had. So if it was something for an acute, which means like flu or a cold or a sinus, or something that was short term, a small percentage of patients would continue taking it. And they'd say it's a minor illness, that's fine, I'll take it, but it's only about 8%. Major illness, that went up a little bit, which was 36% of patients and 44% of GPs. The general practitioners were also interviewed in this study, and they said it was acceptable to take it. And only half the patients that were interviewed thought that the doctor they were seeing or the healthcare professional they were seeing actually knew anything about their religion and how it influenced their medicine use. And just to round off to say that it's still a problem for Judaism as well. Seventh-day Adventists and Orthodox Christians also don't have pork products, and Jehovah's Witnesses actually avoid blood-derived products. So each religion has something within it that is actually influencing their medication use and healthcare service. There was another study done in France, and this was more often she was and now I'm blanking on the word, anthropologist, there we go. So she was an anthropologist, and she went to live within a community, and it was a community made up of Protestants, Catholics, and Muslims in this little town in France. And she started observing their behavior and started talking to them about medicine use. And she found that actually the Catholics thought that taking medicine was actually not a good thing, and they felt guilty about taking it. They were heavy users of medication, but they were more likely not to take it for long term because of this guilt. The Muslim patients, on the other hand, felt that because this was somebody that they respected, that they had to sort of obey, and therefore they would take the medication, and they had an attitude of obedience, but they were less likely to be adherent long term as well. So here's the bit where it says they will stop a treatment if they think they're not having any effect. So if there's no immediacy of effect, if they don't see anything happen quickly, they will stop taking their medicine. And if they have any side effects, and this is dangerous because sometimes you have what we call adverse effects, which are strong, bad effects of medicine, and you want the patient to report that, they're more likely to say, well, that's the medicine working, so let me take more of it. And they had the opinion that the right medicine was something that did something. But they also felt that they would only take the medication when they required it. So if they were chronic diabetic patients or chronic hypertensive patients, once they started feeling better, they'd stop their medication. They wouldn't take it anymore. And so you'd have to have this constant counseling to say, no, actually you have to continue taking your medication. The Catholic patients were more impatient than any of the other groups to see immediate results as well. They wanted to see something having an effect. And they would stop taking it if they didn't see anything happening. And they were also inclined to stop long-term therapy, even if they considered it effective, and most of it was because of the fact that they felt guilty taking this medicine. They felt they shouldn't be taking it. The Protestants, on the other hand, they were more willing to accept the idea of long-term treatments, and they were also more inclined to take charge of their own therapy and their own health care. So they thought actually if they self-medicate, they're taking responsibility for their own health and their own treatment, and they were more likely to self-medicate as well. So that was all about the patients, but what about the healthcare professionals, and how does religion influence the healthcare professionals and how they interact and work with patients and how they manage patients? So again, we did a study in same, it's now called eThekwini municipality. It's still Durban, they just changed the names. And basically this was also done around 2008 and 2009. We have blacks, Asians, mixed race and whites in the province and in the country, but that was the distribution in this particular municipality. Christianity is the dominant religion in South Africa, followed closely by those who actually declare that they have no religious basis. And then the growing groups are the Hinduism and the Muslim population as well. So we conducted the survey with general practitioners, specialists, pharmacists, any healthcare workers, and we did a sample of 224 medical practitioners and 300 pharmacists. And we asked them about things like, obviously their gender, their race group, their age, how many years they were in practice. But we also asked them questions about spirituality of themselves and spirituality of their patients, and whether they had any knowledge about religion and medication use and interactions in that regard. So we asked these questions. It wasn't a very long, but we ended up with a nice sample size. So 190 doctors and 238 pharmacists participated. Most were males. It is changing. Both those professions are becoming more female dominant. It was the largest group in that was again the Indian population, and that's actually the characteristic of the Durban municipality in terms of healthcare professionals as well. So, what did they say? A lot of them said they were aware of dietary restrictions in relation to religions of patients. And they said, yes, they consider this when they prescribe and when they interact with their patients. They all knew about alcohol and they knew about gelatin being a problem. A smaller percentage knew about the bulking agents such as stearic acid. And most of them said they would prescribe an alternative if they knew that there was an alternative available that didn't contain any of these products. But when you provide them with actually the trade name of these medicines, they didn't even know that they contained these problematic ingredients. So while they had the knowledge of the religion and some of the products, like the excipients, they didn't know which medicines actually contained those ingredients. And then pharmacists were more likely to be aware of the fact which products, the actual brand name products, had problem ingredients. And they were also more likely to be aware of things like gelatin and glycerol, the more common excipients that are problematic. However, the doctors were more likely to query from the patient about their religious affiliations when they're talking to them and counseling them and prescribing to them. And patients were more likely to talk to doctors rather than any other healthcare professionals about religious issues and the problems they might have with religion and medicine use. The doctors felt that they had more time and more training to be able to do this. Pharmacists actually indicated that they were a little bit unsure of how to deal with this with the patients, and they weren't capacitated enough to be able to bridge this topic in a counseling session. So what does this all mean? Well, it's important because of the fact that if you know about what faith someone comes from or what culture, because it might be a dietary issue, you're more inclined to be sensitive about the medicines that you're going to use and how long you're going to be able to use them for. So, in a sense, if you're a patient, it is important that when you interact with your healthcare provider, you actually talk a little bit more about the restrictions you might want or you might have in your life in terms of diet, in terms of religion, for the medicines that you might be able to take or not take, and that's called informed consent. You then consent to the treatment that going forward. And again, if it's a major illness and there are no alternatives available, then at least you've discussed that and you feel more comfortable about choosing that option. It improves your clinical relationship with your healthcare practitioner as well, because if they are aware of your restrictions, even if you're buying something over the counter or you're self-medicating, your pharmacist, if they have the history, is more likely then to be able to tell you, I think you might have a problem with this particular product, and suggest an alternative. And then also because of the fact that you're no longer placed in that vulnerable position of saying, I'm not participating in this interaction, and I'm going to just take whatever's being prescribed to me and then let it sit on the shelf. That's actually not what you want to do. And that's a wastage of time, effort, and money anyway, both to you and to the system. So it's all about communicating effectively with your healthcare practitioner and being able to say, you know what, I do have some issues and I'd like them to be considered in my healthcare and in my medication prescribing and dispensing. So create an opportunity for healthcare professionals to now do, you need to create an opportunity to discuss these issues with your patients as well. You have to be able to say, you know, what can we do? Do you have any restrictions? Are there anything that we should consider before we move forward on your healthcare? And it's developing a general knowledge. You don't have to know every religion or every issue absolutely in depth, but if you have a sensitivity about it, then it's actually nice to develop that general knowledge about the sensitivity and to just communicate effectively with your patients about it. It's also about creating links, so not feeling alone in this sort of thing. What we've done in South Africa is we've actually created linkages with religious leaders and religious associations, and they're starting to talk to the healthcare professionals, and they've developed websites now that have a list of medications that actually are prohibited by that religion, and patients can go in and check, as can healthcare professionals. But they've also left contact details with their healthcare professionals, and these people can pick up the phone and say, I want to do this with my patient, is that permissible or not? But more importantly, where there are no alternatives available, these religious leaders have now told the community that in instances of these conditions, these are the only medications available and it's permissible for you to use it. So they take away that guilt factor, and patients are more likely to stay on their therapy if that's the case. And that's what I mean about collecting information. So if you don't have the linkages, go and talk to the community. Find out who's the person that they will most likely listen to and most likely be the person that you should create as your emergency contact in situations like this. What we've also done is create multidisciplinary working groups. So we've brought together pharmacists, medical practitioners, social workers, nurses in organizations to actually discuss this a lot more and create awareness about these sorts of issues. And then they create awareness within their particular practice settings, and then it has a knock-on effect to the point that at the moment in South Africa, if you want to know whether something's vegetarian or not, even in terms of multivitamins that are available over the counter, we now on the label say suitable for vegetarian use. So our labeling in South Africa has changed, and most of our vitamins in that also say contains alcohol or contains gelatin. So people are much more aware about what's going on with their medicine use. And that sensitivity is now being seen in medicines labeling in South Africa. And I'm going to open it up for discussion and questions right now, so thank you all very much. Yeah.
While doing this study, did you find a lot of Christians with the God will heal me mentality?
Yeah, so basically the question is about, while we were doing the study, was there very much the God willing mentality. It's a belief system that you find in patients across different religions. So there are patients that will say what will happen, and they'll either take the medication or not take the medication, seek healthcare or not seek healthcare. So despite that mentality, it has no bearing on whether they take the medicine or not. It's just whatever their belief system is in there, whether it's a natural progression of disease, they'll stay with the natural progression of disease, or they feel it's their imperative to seek healthcare, they will seek healthcare. Sorry, go ahead.
Did you guys have any definitions for religion? Because even though within each religion there are people that have, strange beliefs and that can also affect their views on medication, just curious.
No, we kept it broad because you could go down to, and the issue also was because of the fact that we wanted to have a sample that produced something. If you try to get down to those subcategories, you actually have to then interview about 10,000s of people to get to those kind of categories for it to be meaningful. Yeah. Sorry, yeah.
Is there a universal healthcare system in South Africa? Is there a question as to cost?
We're actually moving towards a universal healthcare system. So now 80% of our population is seen in the public sector, and 20% are in the private sector, which is under the medical insured or out-of-pocket system. In the public sector, we have an essential medicines list, and that's all that you will get available in the public sector. The private sector has everything that's registered in the country. So the access is different, but the government has tried to ensure that whatever budget they have covers the majority of the conditions and the majority of the population as well. But they're still very sensitive about religious and race and gender issues in South Africa because of our past. So the issue of having medicines that are suitable for all religions is something that they take very seriously. So Julie.
Could you make some observations about our Affordable Care Act and what you might use from that in South Africa and what South Africa might share to tweak our existing system to make it more accessible?
So it's about the comparison of Affordable Care Act and what lessons we can learn from there and what lessons you can learn from South Africa in that regard as well. So let's just state very clearly, we're very early in our universal health care approach in the sense that we haven't even legislated it yet, but we're moving to make our systems suitable so that when it's implemented, it can go smoothly. So for example, in terms of what we've learned from even before the Affordable Care, but as you were moving towards it, is the outsourcing of patient care to the private sector. So we have general practitioners that are in the private sector that see public patients. We also have private sector pharmacies that are either postal pharmacies or community pharmacies that provide medication to patients. And these are all pilot projects that are going on in South Africa at the moment. We're taking it slow because we have learned that to get our systems right before we start something, because they are always, and to start small and build up, because there are always glitches if you try to go too big too quickly. We also have learned about making sure that all stakeholders are on board before we implement the system, so that there's not tension within the system and patients don't know what's going on and then they distrust what's coming. So from the Affordable Care, or not from the Act itself, but the approach towards implementing it, we've learned about actually being a little bit more encompassing, which is why it's such a slow approach.
Get that.
That's Siri. I mean, and that's the best I can do at that particular point in time, because until we see the white paper on universal health care in South Africa, which is supposed to be before the end of this year, we'll know what aspects were included and not included.
Are you a part of the policy maker, decision maker?
So am I part of being a policymaker? I would have loved to have said no, but yes. I chair the committee on pricing, the pricing committee, the National Pricing Committee in South Africa, and that's the committee that actually regulates medicines pricing in South Africa. So we set the price at which a manufacturer can sell a medicine to wholesalers and pharmacists, and we also set the maximum dispensing fee that a pharmacist or a non-pharmacist can charge to dispense a medicine. I also sit on the committee for the task team that's looking at reviewing the adult medicine list for hospital care for the public sector. So, yeah, I guess I'm part of being a policymaker.
Is the pharmaceutical industry as huge in South Africa as it is here?
It's not, well, is the pharmaceutical industry as big in South Africa as it is here? It's not as big as it is here, but it's definitely not a small enterprise either. We have local companies that now have subsidiaries in Australia and UK, so they've grown, and we have multinationals that actually have base in South Africa, so people like Pfizer and Bayer and so forth. And the reason is because South Africa is seen as the inroad to the rest of Africa. We have a strong regulatory authority called the Medicines Control Council who registers medicines in South Africa. And a lot of the other countries have agreements with South Africa that once that medicine is registered in South Africa, it'll be available in their countries as well. So the pharmaceutical companies see a need to be in South Africa. But let me also explain to you about why they think it's so critical. So we try to change our patent law, which is how long a medicine can be existing in the country without any competition, to put it simply. And we had tried to take over all the laws that allowed them to continue that registration and be the only medicine available in the country for a while. And we actually had the American companies try to put together a plan to disrupt that law. And it was actually leaked to the press. So it is actually an industry that's seen as very viable in South Africa.
This is just an observation. I saw that on the slide, Orthodox Christian doesn't eat pork. So that would be the same with Muslim?
Yes.
But in your questionnaire, you sort of didn't ask whether they can take medication that is extracted from pork, for example.
I actually did. I didn't present all of it. So when we gave them the brand name of the medicine, so some of the insulin actually has pork derivatives in it. There was a list of 10 brand names that we gave them, and some of them were capsules that had pork-derived gelatin in it. And the healthcare practitioners actually didn't know that some of them had pork products in it. And some of so I didn't present the patient side of the last research that we did, but some of the patients didn't even know. And when they were asked if they knew if any of them were not allowed in their religion, they said they wouldn't take them. The Christians included. And then we had a question for the patients to say, what if this was the only one available for you and your religious leader permitted the use of it? Then about 60% of them said they would take it. But not all of them. Some of them still said they wouldn't take it. Yes.
Can you speak at all to the additional barrier of language? We do a lot of interpretation and translation in our organization. We find that there's a great deal more conflict or ethical issues when it comes to communicating whether you would like to ask questions or more questions of your doctor.
Yeah, so it's the issue of language and how that impacts on medication use in healthcare. South Africa has 14 official languages, so we see that happening all the time. And what we've actually discovered is that, especially for somebody like who comes from KwaZulu-Natal, where Zulu is the predominant language, there sometimes isn't words in that language for the medical terms that we want to get across. So we're working with the community to actually create a medical dictionary, so that we train people who are from that culture in our universities regarding those issues so they can go back to the community. But we've been also training our interpreters about what we're trying to do, so that when they do the interpreting for us, they know exactly what we're asking for. And if the person doesn't understand the medical term because it's not commonly used in their language, they find the synonym. But it is a problem. What we've also done in our university is actually make Zulu mandatory for all university students. So they actually learn Zulu so that they don't have to talk through an interpreter, and we don't have that issue of mix-up in communication. But for a while we did have that issue. But so what we've done is we've made training. You have to learn, pharmacists all learn medical Zulu and basic Zulu so they can communicate.
Is that well received?
Oh yeah. I mean, and now actually we started with health sciences only doing this, but now actually across the entire university at UKZN, Zulu is actually a mandatory subject across all courses and programs. So that's what we've done.
I was just wondering, when you were talking about kind of the solution
point, actually. I saw something trying to happen in Chicago when I was there a while ago, but I haven't seen it actually being built up to that extent. And I've actually tried to go into the stores and see what's on the medications for over-the-counter and that, and they don't even tell you whether the gelatin is animal extract or vegetarian extract. So I guess it depends on the sensitivity of the population, because we're so sensitive about it in South Africa. We actually have a paracetamol, which you call acetaminophen here, sort of for children, and it says no alcohol, because then most of the Muslim patients and most of the Orthodox and the Jewish patients will not take alcohol even for their children. So cough syrups will tell you contains alcohol or doesn't contain alcohol. So our labeling is very sensitive for medicines back home. But I mean, Sally's here. Sally can say whether anything's happening here in Des Moines.
No, I wouldn't kind of echo that, but I don't know if that was your question or related to the healthcare team.
Yeah, no, just like if any efforts were like that anywhere, any person here, a doctor or a pharmacist, kind of working on that at all.
I think, and maybe this segues into my question for you too, as far as the education that's provided to physicians and pharmacists over in South Africa related to cultural aspects. So you found in your research that there was a need for more of that, but what's currently going on and how can we improve that for our students?
So the issue is all about, sorry, I'm repeating the questions for the sake of the recording. So the issue is about the training and whether we do culture sensitivity in our training of doctors and pharmacists back home, and whether we can improve on that. We do culture training, and it's basically also in these kind of counseling and patient interactions. We do make it very clear to our students when they are being trained as healthcare professionals, including the nurses, to ask about these sorts of things. The problem we've discovered, and that's where this research has fed in, is that we tell them the problem ingredients are things like gelatin and alcohol, but we don't tell them where to look for it in the branded name products. And so they know the sort of issues that are problematic with faith and diet. They just don't know the brand name of the product that might be a problem. And that's why we started working with the religious leaders and the pharmaceutical industry and so forth to make labeling as well as the websites very clear as to what that is as well and what they contain. So because you can't actually teach a student everything and every brand name and every excipient, we tell them in the main things, and then we now showing them on labels where to look for it. And we also trying to make websites where we say this is the alternative. So if you can't take, for example, a ibuprofen capsule because the capsule is gelatin and it's gelatin from a meat or a animal derived gelatin, then the alternative is the ibuprofen tablet, because that one actually is vegetarian suitable. So we kind of give them those kind of alternatives. Is that it? Is that too much information all at once? All right, thank you.
Any closing remarks, or just?
No, just once again, thank you all for coming, and thank you all for the discussion afterwards as well. I really appreciate the questions as well.
And we thank you. Thank you.
Thank you.